Tokyolive
Endoscopy
1.
Hello and welcome to Tokyolive. I'm Shyam Varadarajulu from Orlando, Florida, and my co-moderator from Taiwan is Professor Supo Wang. This section is dedicated to biliary drainage. We have two outstanding speakers for this section. The first speaker will be Professor Yosuke Nakai. He's an associate professor of endoscopy from the University of Tokyo Hospital. He is not only a gastroenterologist with special expertise in interventional endoscopy, he is also a PhD graduate who spent 2 years in the United States undergoing advanced endoscopy training at the University of California in Irvine. Professor Nakai expertise is in pancreatic and biliary interventions and tumor oncology. He will be speaking to us today about endoscopic management of bile duct stones. And the second speaker today will be Professor Hiroyuki Isayama. We will now go to the first speaker, Professor Nakai, who will now talk about endoscopic management of bile duct stones.
Thank you, Shyam. I will share my screen. So it's my great honor to participate in this great conference. So I will talk about endoscopic management of bile duct stones. So there are some types of stone, like large stones, small stones, hard stones, soft stones. So I will focus on large stones and small stones, and then I will get touch on the bile duct stones in the surgically altered anatomy. The history of therapeutic ERCP started in 1970s by the advent of endoscopic sphincterotomy. In 1979, a Japanese multi-center study of sphincterotomy for over 400 bile duct stones was reported. In this report, technical success rate was over 95% for endoscopic sphincterotomy. However, the success rate of the removal of bile duct stone was about 86%, and most of the stones were removed by spontaneous delivery, which means at this point, there's a lack of dedicated bile duct stone removal devices. So when we treat large bile duct stones, how can we manage them? We can make the stone smaller introductorily by the lithotripsy, like a mechanical lithotripsy or cholangioscopy or S-wall. Or the other option is to make the ampulla wide open by the use of large balloon dilation. In 1980s, mechanical lithotripter was developed, which is a basket with a metal sheath. By use of this mechanical lithotripsy, now we can remove the large stone by breaking the stone in the bile duct. And the other option is a cholangioscopy with the introductal lithotripsy by EHL or laser lithotripsy. In this first report, larger than 2 cm stones in 9 cases were successfully removed by the EHL. And the other option is a large papillary balloon dilation. After cutting the ampulla by the ES, we can dilate the ampulla using a large balloon and then remove the stone with a lithotripsy by the balloon extraction. So which is better, EPLBD or endoscopic sphincterotomy? In this meta-analysis, the stone removal rate is higher in EPLBD, and the complication rate is lower in the EPLBD too. And the use of mechanical lithotripsy is less often in EPLBD and the procedure time is shorter. So I think EPLBD is now the standard of care for the large bile duct stones. So however, we have to be very careful to select the right persons. Like figure A, dilated CVD is the good indication for EPLBD. However, in small bile duct stone, small bile duct cases, you cannot use the EPLBD. Or if there's a case with a distal CVD stricture, there may be a risk of perforation, so we have to be very careful. And the other controversy is use of sphincterotomy before large balloon dilation. We conducted a randomized control trial comparing the EPLBD without ES versus ES, called Marvelous trial. In this randomized control trial, stone removal rate is higher in EPLBD without ES, and the complication rate is comparable. So I think we can omit ES before EPLBD. And in the right column, this is a meta-analysis of EPLBD alone versus EPLBD with ES. In this meta-analysis, complete stone removal rate and complication rate are both comparable. So if you have some difficulty in ES before EPLBD, like a case with a diverticulum or in patients with surgically altered anatomy, then we can skip sphincterotomy and go ahead to large balloon dilation. And how can we choose cholangioscopy guided lithotripsy versus EPLBD or mechanical lithotripsy? There are 3 randomized control trials. In these 3 studies, the stone removal rate is higher in cholangioscopy guided lithotripsy. And in one study, the procedure time was longer in cholangioscopy guided lithotripsy, but the radiation exposure was shorter in the cholangioscopy guided lithotripsy. And in the second study by the Biliary group, in the case with the tapered distal CVD, mechanical lithotripsy is necessary after EPLBD. So we can consider cholangioscopy guided lithotripsy in those cases. And this is the algorithm they provided in the paper. Like the case in the left, if the stone is larger than CVD diameter, then we can go ahead to perform cholangioscopy guided lithotripsy. But in the right, in this case, the stone diameter is smaller than bile duct diameter. In those cases, we can treat these stones by EPLBD. And if we fail, then we can convert to cholangioscopy or mechanical lithotripsy. So I think this kind of algorithm is very useful for physicians because if you just do this and do that, and then it's not cost effective and take longer procedure time. So we have to be, keep in mind this comparison of stone diameter and bile duct diameter to select the right procedure. And I will move on to small stones. This is reported in 1980. And this is reported as an alternative to sphincterotomy because sphincterotomy has a risk of bleeding or perforation. And this Japanese multi-center study compared ES versus EPBD for small stones called JSET study. The efficacy was similar, but the EPBD has a post-ERCP pancreatitis. However, in the long-term outcomes, because EPBD keeps the sphincter function, the less late biliary events were observed in EPBD. However, because of the high risk of post-ERCP pancreatitis. It is not used as a standard procedure. It's now used for only patients with severe coagulopathy, like a cirrhosis patient or dialysis patient or patient on antithrombotic agents. And the Taiwan group tried to overcome this complication of post-ERCP pancreatitis by use of the 5 minutes EPBD. In this randomized control trial, post-ERCP pancreatitis reduced by the use of 5 minutes EPBD, and the efficacy was also better. And of note, in the long-term outcomes, 5 minutes and the 1 minute EPBD was comparable. So I think we can choose this option for small stones. And more recently, small ES plus EPBD was reported as useful for small stones. This was a Juntendo University study. It's a retrospective study, but the ESBD, small ES plus EPBD showed a better efficacy, and post-ERCP pancreatitis was comparable, and the bleeding was less often in the use of small ES plus EPBD. I think this should be confirmed by the randomized control trial. And which device we should use for small stone, basket or balloon? There are 3 randomized control trials, 2 from Japan, 1 from Europe. And two studies show the complete stone removal rate was higher with a balloon, especially in cases with a stone number less than 4 or small CBD or small stone diameter. So in those cases, I think we should use a balloon catheter to remove the small stones. And finally, I will talk about the bile duct stone in surgically altered anatomy patients. There are 2 options, EUS guided antegrade stone extraction or balloon endoscope assisted ERCP stone extraction. For EUS guided antegrade stone extraction, we can get a biliary access under EUS guidance from the intrahepatic bile duct, and then pass the guide wire through the ampulla, and then balloon dilate the ampulla because we cannot perform sphincterotomy under fluoroscopic guidance. And after balloon dilation, we can push the stone out using a balloon catheter antegradally. For balloon endoscopy assisted ERCP, we can reach the ampulla use of the balloon assisted endoscope, and then again balloon dilate the ampulla. And then finally we can remove the stone retrogradely. So these are 2 options for endoscopic management of bile duct stone in those patients. And this is a retrospective comparative study from Juntendo University. For biliary access, EUS guided approach has a higher rate of biliary access, over 85%. But the stone removal rate was comparable, about 70% in both EUS and ERCP. And the complication rate was higher in EUS guided approach. I think this is because from the minor bile leakage. And this is, for this topic, there's a ongoing prospective multi-center randomized control trial in Japan. However, these results may differ by the anatomy because in Japan, in those cases with altered anatomy, the patient has a surgery for gastric cancer in most patients. However, in the Western countries, most patients have a Roux-en-Y gastric bypass surgery. So endoscopy assisted ERCP is difficult because the limb is longer. So EUS guided approach is preferred using the lumen opposing metal stent. In this comparative study, EUS guided approach has a higher technical success rate and the shorter procedure time and the shorter hospital stay. So we have to choose the approach by the patient anatomy. So this is my last slide. For large bile duct stones, mechanical lithotripsy, EPLBD, or cholangioscopy-assisted lithotripsy are the options. However, in cases with the stones larger than distal CBD size, cholangioscopy-guided lithotripsy is preferred. And for small stones, we are now doing a ES, but small sphincterotomy with a balloon dilatation may be a good option in the future. And in cases with surgically altered anatomy, EUS guided approach, antegrade, or endoscopy guided approach, retrograde can be selected according to the anatomy of the patient. Thank you for your listening.
Okay, I will introduce our second speaker. After that, we have a discussion. Our second speaker is Professor Hiroyuki Isayama. He is a professor of Jindaton University. He is an interventional endoscopist, also oncologist. He has published more than 400 papers, and also has been invited for live demo, lecture, and the workshop. And besides that, he also joined the committee of many guidelines, including the biliary pancreas, cholangiocarcinoma, and also is the chief of the subcommittee to making the guideline. And his major is in the ERCP and the interventional US. And he also the president of TCAP, a very famous international workshop held annual. So today he will give a talk about the US endoscope drainage of biliary, strategy of endoscope drainage. Hiro, please.
Okay, thank you, Shupo. Very kind introduction. I want to thank to the both Sham and Shupo, and special thanks to Professor Haruhiro Inoue to give me a very good opportunity to express my recent work. So today I will talk about current strategies of endoscopic biliary stenting. So today it's my topic, so limited in ERCP, because many doctors will talk about interventional endoscopy, especially biliary drainage. So this is my COI. And firstly, I want to introduce my recent works. First one is Tokyo criteria. So this is a standard reporting system for transpapillary biliary stenting. So very long time we use terms of the stent patency, but recently I think recurrent biliary obstruction, including occlusion, migration, kinking of bile duct, are more suitable than the patency. And time to RBO is also a very important evaluating system. Now we Japanese is renewing this criteria, so it expanded to the interventional EUS. We will express our new criteria maybe next year or 2 years later. And the other, my work is study about mechanical properties of metallic stent. So I think it is very important to understand both larger force and axial force. Larger force is a well-known expansion force and keeping the luminal patency. But axial force is a brand new one proposed by me. And this is related with conformability in the bile duct. And this is a recovery force when the stent bended. Actually, stent is fixed in a bile duct by tumor as a fulcrum, and both sides of the stent may compress biliary wall or orifice of the cystic duct and the pancreatic orifice. And this compression may cause many complications. Then, my opinion, so lower axial force, lower is better. Actually, we analyzed the relationship between adverse event and these mechanical properties. So migration and the pancreatitis and the cholecystitis. So from our analysis, so adequate or higher larger force with very low axial force is a ideal mechanical property. Recently, we published this data. This is named watch study comparing the covered wall stent versus covered wall flex. The material changed, stainless steel to nitinol, and the larger force 40% up and axial force 30% down. So from our result, covered wall flex showed a longer time to RBO because of the reducing the migration rate. So I think that it is related with the mechanical properties. This is a recent our analysis. So we re-evaluate current stents, and from our result, we can classify the stent according to the stent structure. So cross-wire structure, hook and cross. So most of the stent from Korea, and the laser cut stent. And look, hook and cross is a adequate larger force and very low axial force. And the crosswire design, so represented by Wolflex, the very high axial force and adequate larger force. And the laser cut, so adequate axial force and a very high larger force. So we should analyze the clinical result according to the these stent structures. So we will publish this data recently in the near future. So back to the clinical situation. There are many situations for the endoscopic biliary drainage. So causative disease, tumor location, tumor status, virtual surgery operation, and we can perform the many endoscopic procedure. In this lecture, so I limited my talk about ERCP. So, and I want to introduce this international consensus guidelines of endoscopic management of distal biliary stricture. So we, 3 societies, so conducted this activity and recently published. The 24 experts from 11 countries gathered 4 years ago. Initially, brittle surgery or distal stricture. So this is recommendations from the international consensus guidelines. So which patient require endoscopic biliary drainage before surgery? So routine biliary drainage should not be performed. But patient with cholangitis, NAC case, and delay in surgery, we should perform the biliary drainage before surgery. And the stent selection. So metallic stent is better than plastic stent. This is a pooled analysis from the Dutch group. So from them, early surgery is best. But if they perform the biliary drainage, fully covered metal is better than plastic. But it is an upfront surgery case. This is a Japanese study for feasibility in upfront surgery using the fully covered metal. So fully covered metal is feasible. But recently, the current strategy for pancreas cancer is no upfront surgery. So most of the case required chemotherapy before surgery. So and neoadjuvant chemotherapy is now standard of care. So and also our endoscopic biliary drainage strategy is changed. So this slide shows a Japanese feasibility study using a partially covered metal stent for neoadjuvant chemotherapy. The pancreas cancer. And from the USA, Jeff published this data, MD Anderson. Wall stent is better than plastic stent in neoadjuvant chemotherapy cases. And this is a comparing study, free covered metal versus uncovered metal, because Jeff's data including both uncovered and free covered metal. And from our result, the free covered metal and the uncovered metal is comparable, but including the many cases of the unresectable case after the neoadjuvant chemotherapy. And personal, my opinion is free covered metal is better. It is a summarize of the strategy for the bridge to surgery. Upfront surgery, no requirement of the routine biliary drainage, and patient with cholangitis or dry surgery case require the biliary drainage. Neoadjuvant chemotherapy, biliary drainage is mandatory to keep the chemotherapy schedule. And metal is better, and the covered and uncovered is comparable now. But a very important thing, still many surgeons hesitate metallic stent. And then in Japan, many studies is conducting or ongoing. Move to the palliation distal stricture. So this is from the international consensus guideline. So metal is better than the plastic. And covered is recommended by our group. These studies are comparing the metal versus plastic. So uncovered and partially covered. Both metal stent showed a longer time to RBO. And comparing covered versus uncovered. These studies are from Japan. Both are recommended at a cover. So because of the longer time to RBO. But still controversial, which is better, covered or uncovered. So from the many RCTs, covered and uncovered. So in technical success rate, adverse event rate, similar. But TRBO, so time to RBO. So some RCTs cover is better. Some RCTs are almost same. And cover has an additional advantage, so removability. So then if the stent occluded, so using the covered metal, we can easily to perform the re-intervention. Then some guidelines recommended the cover. So and recently, for the palliative cases, there are many effective chemotherapy and the patient survival prolonged. And we should consider about prolongation of the time to RBO, and we should perform the more re-intervention because of the longer patient survival. So one trial is using the larger stent. So I asked to the Korean company to make a larger bore stent, so 12 millimeter in the diameter. So now Japanese group performing the comparing the study 12 versus 10. So Dr. Mukai will present this data in the near future, and from their data, the 12 is better. And for chemotherapy, so this is a recommendation from the international consensus guideline. Chemotherapy does not appear to increase stent occlusion, but increase stent migration. From the Dr. Nakai's data, So no difference in a stent occlusion, but stent migration increased in a chemotherapy group. Then a very important thing is to avoid to prevent migration. From Professor Kitano's data, so flare, so direction is very important, and the square diameter is better than simple flare. So now we are evaluating the large bore big head design stent. So named Hiruzo from the Korean company. So this is our retrospective analysis. This analysis comparing patient with migrated stent, so 10 millimeter stent, and in these cases, we placed 12 millimeter fully covered metal stent. 12 millimeter fully covered metal stent showed a longer time to RBO, very low rate of the instance of the migration. So then now we are indicating the 12 millimeter big head design stent for the initial cases. Okay, this is a summary of the variation. So carbon metal is the first choice. And now there are some effort to prolong the time to RBO, anti-migration, or larger bore stent. And the prolongation of the patient survival, so more chance to occlusion. So exchangeability is very important. And for the chemotherapy cases, covered metallic stent with anti-migration system is very, very important. Move to the higher variation. So there are many type of the stent insertion. From Korean RCT, bilateral stenting is better than unilateral. From China, Fubin published this data. Bilateral metallic stent is better than other type of the stenting manner. So uncovered, single man uncovered, or using the plastic stents. But recently, so also cholangiocarcinoma patient survival prolonged. Then Japanese guidelines for variation cases. So both plastic stent and uncovered metal stent equally recommended. So because the occluded metallic stent, the intervention is very difficult. So then many Japanese endoscopists select plastic stent rather than the uncovered metal actually. Then we guideline committee so decided to this recommendation. And some trial to prolong the exchangeable stents. Firstly, plastic stent. So we are performing the RCT, comparing this inside stent versus a conventional stent. Inside the stent, place the stent above the papilla, and can avoid the stent occlusion by food scraps, and may reduce reflux of the duodenal contents. Now RCT is ongoing. Other promising the stents are slim covered metal stent. So very interesting thing for distal stricture. So diameter of the stent increased up to 12. But for Hilar, so reducing the stent size. So now we are evaluating the 6 millimeter fully covered metal stent. So we so-called slim covered fully covered metal. And this stent showed a very good result. And this case series, including 37% of the business type 4. So then we should evaluate these exchangeable stent prospectively. This is a summary of the variation of the Hilar stricture. Stent selection uncovered metal and the plastic stent equally. So because of the difficulty of the reintervention in uncovered metal and the recent development of the chemotherapy, the patient survival prolonged and we encountered more occlusion. The exchangeability was required for the stent. Then we are evaluating the inside stent and slim covered metallic stent. This is my slide. Thank you very much for kind attention. Conclusions. Stent selection according to the patient status, BTS, variations with or without chemotherapy, and distal or Hilar. And we should renew the strategy according to the prolongation of the patient's survival because of the effective chemotherapy. So anti-migration and exchangeability is a very important keywords. Thank you very much for kind attention.
Okay, thanks, Hiro. Let's go on the discussion. We will start with the Professor Nakai's lecture. Okay, Shine, do you have any comments or questions for Professor Nakai?
I had a great opportunity to learn about all his research from the slides that Professor Isayama had presented. I was not aware that he had done so many cutting-edge clinical trials. So congratulations to him.
Thank you.
When it comes to bile duct stones, one of the challenges that I have seen in patients with altered anatomy, because in the Western population, many patients with altered anatomy are there, and this is a huge challenge. So I would like to know what Dr. Nakai's triaging is with regard to balloon-assisted ERCP versus your antegrade intervention. I just want to know his practical algorithm in day-to-day practice.
Okay, so it depends on the local expertise because we can perform endoscope and EUS guided intervention in our center. So we usually select endoscope assisted ERCP first because there is no risk of bile leakage. So we can perform ERCP via physical route. But in cases with multiple histories of surgical intervention, so in those cases, there are many adhesions in the intestine. So in those patients, there's a risk of perforation during the endoscope-assisted ERCP. In those cases, we prefer EUS-guided approach because the biliary access is easier, straight shot.
Do you have any suggestions on how to minimize bile leak following EUS guided drainage? Because I assume you go transgastric, you probably use a cystotome, you dilate, and then all the accessories are removed. How often does bile leak happen, and what tricks do you have to minimize symptomatic bile leak?
Thank you. So we don't use a cystotome because the tract dilation is too large. So we just use a mechanical dilator or balloon dilation. And if the stone is large and if you need a more session, then in the first session, we just put a plastic stent or metal stent. And we don't manage the stones. And after a couple of weeks, there's a mature tract between the stomach and the bile duct. Then we can treat the stones without the chance of bile leakage, even using a cholangioscope. So I think that's a trick to minimize the risk of bile leakage.
And when you place a stent between the stomach and the biliary system, if it is a metal stent, can you please tell us what kind of a metal stent would you place?
Basically, we use a plastic stent because metal stent is not covered by the insurance in Japan. But if I can use, then I'm going to use a fully covered metal stent because we have to remove the stent eventually after management of the bile duct stones.
Okay, thank you.
Professor Nakai,
Yep.
sometimes they are very difficult stone. It's too hard to crush. Do you have any tips to predict the stone is very difficult to crush, and you go directly to cholangioscope with EHL or laser?
Thank you. So I think it's very difficult to predict the stiffness of the stone, but the stone is the shape of the stone is square. Sometimes it's difficult to crush with the mechanical lithotripsy. In those cases, we prefer cholangioscope guided lithotripsy.
How about shine of Professor Isama?
So about hardness of the stone. Previously, we take a CT. So the plain CT showed a very so white stone may suggest a very hard stone. At that time, we will select POCs with EHL rather than mechanical lithotripsy.
Okay, yeah. About the Western experience.
I mean, I think in the West, we really don't use a lot of imaging pre-procedurally to assess the type of a stone. Usually for us, we have a very high threshold to go directly for peroral cholangioscopy. And most people will use the EHL method. That's what we standard use. And then these days, if extraction is unsuccessful, then you just leave behind multiple plastic stents to come back at different time. But laser is the way to go for us these days.
Oh, laser.
I mean, when I say laser, EHL.
In USA, the laser is more than EHL, and actually.
So that's a very good question. That is true. In major centers, EHL is the preferred modality. But if you look at nationwide and you want to see who uses what, it's laser, primarily because a lot of centers borrow the laser from their urologists. And then it is so easy to use them. So that is the reason we use more laser.
Okay, thank you very much.
Okay, let's go to the discuss with the heroes lecture.
Okay.
Okay. Is there any comment or opinion from Shine?
I'm going to ask Professor Isayama a very challenging question directly. So we are seeing more and more abstracts of distal malignant biliary obstruction. And then we say ERCP is successful about 80 to 85% of the time. And then when these patients go for EUS guided bile duct drainage, the success rate is usually about 95 to 97%. And I think there's enough evidence from all the studies. Are we at a point in 2021 that if we have a patient with a distal biliary obstruction from cancer, we should just go straight for EUS guided biliary drainage? Why bother with ERCP? Because even in failed cases, when we use EUS, our success rate is more than 95%.
Okay, thank you very much. A very good question. So from the literature and US guided biliary drainage and transpapillary biliary drainage is almost the same. And for the US guided drainage, almost no pancreatitis. It is beneficial for the patient. But in Japan and also in most of the countries, the ES guided biliary drainage is only in a limited center, performed in limited centers. Still, mainstay is transpapillary. So then in our institution, so if we perform the ES guided biliary drainage primarily, so it is only in clinical trials. But actual clinical care, we still performing the transpapillary. It is also a training for the young endoscopist. It is very controversial, and maybe 5 or 10 years later, maybe transpapillary is reduced, and more chance to perform the interventional ES for distal biliary drainage.
So Shine in USA, US guided drainage is the first choice for distal CVD obstruction, malignant obstruction.
I mean, when we train our fellows with ERCP, and if they cannot cannulate using standard techniques, we find it very difficult to train them in needle, knife, and other advanced interventions. We take the scope and we perform the procedure. On the other hand, if somebody has got an obstructive biliary system, and when you do EUS, it is so easy to see this nice, huge, dilated bile duct and to puncture and place a stent. It is more easy to teach the trainee EUS gated drainage. So even in the very best of hands with ERCP, our success rate is only about 95%. There are about 5% of the patients where we fail. I may be wrong, but the only limitation I have with biliary drainage is in a couple of steps. Sometimes the stent deployment is difficult. I also feel that the lumen opposing metal stent that is being placed for pancreatic fluid collection may not be the most ideal design for biliary drainage, because there seem to be some stent occlusion. A stent design change has to happen. But I think if we have a good stent, maybe it's just a single dumbbell shape with a long tubular portion on the other side. If it has been designed, I think EUS gated bile duct drainage may become the norm in another 4 to 5 years, and we may not have so much reluctance in placing those stents.
Hiro, for the distal margin biliary stricture, the study maybe a lot is focused on pancreas or bile duct, but how about the emperor cancer? So fully cover, as you in your mention, the fully cover is preferred. How about the emperor cancer?
Emperor cancer. So the clinical result of the emperor cancer is not so good because of the many chance of the food infection. So and also sometimes difficult to performing the biliary cannulation through the tumor. So then recently for the emperor cancer, we performed the interventional ES rather than transpapillary. So so maybe ES HGS is better than ES CDS because motility of the duodenum is poor in a patient with ampullary cancer. Then we selected ES HGS rather than ES CDS.
If in the center they cannot perform the US guided procedure, they will select the metallic stent because emperor tumor has a high rate of migration. If you use the fully cover, so do you prefer the fully cover or partial cover or uncover? Which is better? Which is your preference?
So recently, we have many stent with a very big head design. So and most of the ampullary cancer, so duodenal obstruction may be caused in end stage of the patient's tumor status. So then at that time, we want to switch to the transpapillary to the ES guided or percutaneous drainage. And we want to exchange or remove the initial stent. And the other Japanese trial is using the anti-reflux stent. So there are some new stent with very good valves. So, and it is one option for the primary ampullary cancer.
Okay, thank you. Shang, is there any question coming?
Yeah, I have maybe just only one, maybe a last question for Professor Nakai. So in the United States, for some reason, endoscopists are very reluctant to place uncovered metal stents for hilar strictures. I think everybody is concerned that if the stent is misdeployed, then there's not a lot you can do. So almost everybody will place a 7 or a 10 French plastic stent in the right and the left system. So after you perform your sphincterotomy and dilate a stricture and place a guide wire, one in the right and one in the left system, what is your simple technique for placing uncovered metal stents in patients with hilar strictures?
I think it depends on the type of the stent used in the institution. So we have, in Asian countries, we have dedicated stents for stent-in-stent methods, like a large cell type stents. Then I think the first deployment of the hilar biliary stricture is not so difficult. But if you don't have these kinds of stents, then maybe side-by-side stenting using a laser cut like a Zilver stent or other type of uncovered stent is technically easier, because once you have a two guide wire through the stricture, it's easy to deploy.
And will you deploy both stents simultaneously or one after the other?
Simultaneously, because we want keep the stent and distal end in the same location of intervention.
Okay.
Dr. Isayama, do you have any words of wisdom for us on how to avoid misdeployment of metal stents and hilar strictures?
It is a very good question. So after the very good chemotherapy result, so some stents are migrated. But compared with distal stricture, the incidence of the migration is not so high in hilar region. And if we select a plastic stent, we Japanese recently evaluated inside stent. This stent designed so very acutely angled one. It is very suitable to avoid migration. So, and two or three slim covered metal stent, maybe a compression at the hilar region may reduce the incidence of the anti-migration. So then compare with the distal portion, hilar, not so many chance to suffer from the recurrent migration. It's my answer.
Okay, I think the time is up. So I have to, before we close, I have to summary today's two speakers. First of all, I think Professor Nakai, in his speech, he has highlighted the mechanical lithotripsy for the large stone, mechanical lithotripsy, EPLVD, and the cholangioscope lithotripsy are choice of the treatment. And the cholangioscope is preferred when the stone are larger than distal CD. I think that's a study from Shine Group. And the for the small stone, maybe balloon is the choice to take out the stone. And the small ESD and the EPVD now is Japan is ongoing. Study is ongoing in Japan. And for the surgical altered anatomy patients, US guided or endoscope treatment can be selected according to the anatomy. So for the Professor Isayama's speech, he talked on the distal and the hilar. For the distal malignant obstruction, the fully cover metallic stain is better than plastic. And we also have considered about the neoadjuvant or chemotherapy. All of that is maybe a cover stain is better than plastic stain. And also for the hilar stricture and the uncover and the plastic stain maybe as choice. And there are also some design a new stand for this purpose. And in the near future, we have a lot of new stand. Also have some ongoing study in Japan to give us the answer. So today, I thanks the two speaker, Professor Nakai and Hiro's professional speech and show their expertise in this field. And I also thanks my co-chair, Shine. It's my honor to co-chair with him. And of course, thanks all of you to join this meeting. The section of video drainage will be closed. Thank you, everybody. Thank you.
Thank you.
Thank you.
Thank you very much. Endoscopy 1.